Our next talk of the day, last but not the least, is by Dr. Feng from Duke University School of Medicine and Duke Hospital, on a topic for neuromodulation for stroke acute treatment, prevention, and recovery. So Dr. Feng is the Chief of Division of Stroke and Vascular Neurology and Medical Director of the Duke Comprehensive Stroke Center, and attending professor of neurology and biomedical engineering at Duke University School of Medicine. Dr. Feng is a board-certified vascular neurologist as well as a physician scientist. His research portfolios included developing imaging biomarkers for post-stroke motor outcome predictions and use of non-invasive brain simulation tools such as transcranial direct current simulation, DTS, vagus nerve stimulation, low-intensity focused ultrasound, and transcranial light stimulation to enhance post-stroke recovery. He's currently leading an NIH-funded $9 million program-wide U01 study called Transport-2, transcranial direct current stimulation for post-stroke motor recovery, a phase 2 study. On the NIH-funded stroke trial network, this is the largest similar study thus far for stroke therapy altogether. He has received over $12 million of NIH funding, SPI. He has been featured on cover pages of Brain Simulation Journal, on numerous book chapters, and features on the Journal of Neuroscience. Dr. Feng received several prestigious awards for his research work in stroke and stroke recovery, including the first Rehabilitation Award from American Heart Association, American Stroke Association in 2015, and then Franz Gerstenbrunn Award from World Federation of Neurorehabilitation in 2016. Currently, he is the section chair of Neuro Repair and Rehabilitation of American Academy of Neurology. He's also one of the 8 at-large members supporting the presidency of World Federation of Neurorehabilitation and North American Regional Vice President. He leads the global mentoring program at the WFNR as well. It's truly a privilege and honor to welcome Dr. Wayne, who's also member of the Chinese American Neurological Association. Thank you, Dr. Wayne.
Well, thanks, Tony, for your very kind introduction. Now I have to live up to your expectation. Can you guys hear me okay?
Yeah, we can hear you. Thanks.
Yeah. By the way, for a while, I always think of CT perfusion, it is a troponin for the stroke, but I'm not sure how many people will agree with me. But anyway, we're not going to talk about CT perfusion today. What we're going to talk about is a neuromodulation tool for stroke acute treatment, prevention, and recovery. And this is my disclosures. And as we all know, in the last 20 years, there's a tremendous breakthrough in the acute stroke care, and now we have 2 thrombolytics and alteplase and tenecteplase. We have revolutionary several tools, endovascular tools. We have stroke mobile units can really rapid and treat a patient. We have a Theta stroke network able to provide expand access to a lot of patient rural area. We create and acting fast or be fast, really increase the public awareness. On the second prevention sides, and really understand a lot of ethos and cardiac embolism, and it was new and medications really prevent cardiac embolisms. You find a lot of breakthrough really centered around acute care and prevention. In stroke recovery, still a little bit struggle. In 5 years, only published 6 papers, and was just 44 papers, and actually in the 3 big journals. Where really establish all the evidence. And how we achieve the stroke outcomes, I'm always thinking, we have to do together. You have to provide a quicker treated patient in the first place, so you can preserve the brain. Once you put back and preserve the brain, and then patient will be much better off and with their recovery. We need we really need to put figure out all the etiology for the stroke, and implement a very effective second stroke prevention, so we can prevent a second stroke and prevent further brain loss. And then we really can implement a brain plasticity and through various rehabilitation tools, so we can maximize stroke outcomes. And what I call the 3P approach, and we have to do all together. And otherwise, I can tell, sometimes we are really frustrated, and if we just spend 3 and 4 months and patient work with rehabilitation therapist, achieve a good recovery, then they have another stroke, and then really they just cannot recover at all. So we'll all have to and work on acute treatment, prevention, recovery all together. um um Despite all the breakthrough, one really neglected area and probably is neuromodulation, and this actually been flourished in the last 20 years. What is really modulation? That might be the first question you have. It really involves activating or inhibiting the neural system, and with one format of stimulation, such as electrical stimulation, light stimulation, ultrasound stimulation. Sometimes we call it magnet stimulation, but in reality, it is actually and the magnet generate electric stimulations, and it can be delivered by electrodes implant your bodies, or maybe just non-invasive through electrodes and place certain part of the body and either on the scalp or one part of your bodies. And the picture below really can show you there are so many ways now you can galvanize the brain and really change the neural circuits and change the excitability and induce behavior changes and with the goal to change the clinical outcomes. When I'm talking about neuromodulation, a lot of time people think of it, it's only used for recovery, but it is really extend to acute treatment as well. Here's a few examples. The Sphenopalatine ganglion is one that and a ganglion actually has a rich source of parasympathetic innervation to the anterior and cerebral circulations. And if it's stimulated, vessel will be dilated, and there's a tremendous blood flow goes to the brain. So in the preclinical and animal model, stimulated in SPG really can increase blood flow, reduce infant volume, and reduce the damage to the BBB, and then actually improves the outcome if you do an early after stroke. The procedure itself is sort of invasive, but it's a very simple procedure, can be done in the emergency room, without a really general anesthesia, and it's very easy to implement. And with this, there's a 24A and Impact 24A and Impact 24B study, and then really targeted those patients. Really is augment the cerebral flow and neuroprotector, and also improve the outcome at 3 months. This study was a global study, and really targeted patient with a moderate to severe stroke with NIH ranging from 7 to 18, anterior circulation less than 24 hours, and once the patient is implanted, and patient either receive active sham stimulation every day, and for 4 hours, and every day, and then continue for 5 days, really try to rescue the penumbras. But the study is sort of kind of exciting, but at the same time also kind of disappointing, using the intended to treat a population, which is everybody. The study didn't really show any positive and a separation between the active group and was placebo group. However, in about 25% has cortical involvement, which those patients actually had a pretty good collaterals, and a p-value is 0.03 is significant. The issue is there's only about 25% of patients in this total populations. That kind of put a device company a little kind of dilemma, and they also think the Impact 24A has a few area can be improved, but they didn't really just want to focus on the cortical involved populations. So they designed a second study, pivotal trial, and really hoping with all the changes can and have a positive study. Instead of have a double masking, they actually have a triple masking, involve patient, clinical provider, all the outcome assessors, and and um, 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 and then the also changed the inclusion criterion a little bit, and uh, and they really focus on still less than 24 hours, but they want to hope to start and randomized start treatment in between 8 to 24 hours. Unfortunately, results still come up very similar to the IMPACT 24A. Overall, the group didn't really show any separation. However, this time they actually involved quite almost a half of those patients actually have a confirmed cortical involvement, and the p-value is similar as 0.025, and then that it just didn't get FDA approval. So I'm not sure what they were gonna do as a next step. I personally think they need to do another study with all the patients with cortical involvement, but that may be limited to their patient populations. Let's quickly work on the light stimulations. Light at a different wavelengths, and actually can really provide energy to the mitochondria, and can mitigate some tissue damages. And is this actually being tested for an acute therapy before the endovascular therapy gain a success? This was done in the NEST 1, NEST 2, NEST 3, and really in the early 2000. Unfortunately, all those trials being failed, but retrospectively, there are a lot of things we can learn. There's a tremendous gap between the animal model and the human models, and the stimulation is kind of and probably need to be a little bit better and formatted. The way they deliver is every single point only deliver two minutes and then move on, and the hoovering basically just stimulate for 20 points for 40 minutes. I personally think it need to be stimulated much longer. So there is really a lot of enthusiasm this moment to revisit this light stimulation. Maybe you can use as a neuroprotector, not a really treatment tool. I personally think there's a lot of potentials. You probably heard a lot of transcranial direct current stimulation. Depends how you place the electrodes. You actually can inhibit the perilesion area and can flow, freeze the penumbra, and might be able to buy more time when you transfer patient from rural area to the comprehensive stroke center. There are inconsistent data at this moment, and on the left side, it was done by UCLA, really shows there are some signal and is safe and conduct such a study in the very acute and within the 24 hours. On the right, this was a European study, but they had a very big inclusion criteria. I personally believe patient can be a little better selected. That was turned out to be a negative study. And in the dosages, the electrostimulation, I think, is also can do a little bit better. This was done in my lab, really kind of using it in, deliver an electrostimulation in patient with Parkinson's disease, use their DBS electrodes to measure the voltage gradient, really kind of to tell, how we should have an optimal dosage, and really can show you, we'll probably even deliver even higher than 4 milliamp, and then the question is whether this will be tolerable to the stroke patient or not. But at this moment, the study I just showed you only done at 1.0 milliamp and 1.5 milliamp, a lot of current being shunt at the scalp and the bone levels. I don't think there's a whole lot of actually electricity penetrate to the brain. So anyway, let's move on the stroke prevention side. Actually, there's a lot of actually neuromodulation tool and also work on second stroke prevention, mainly really focus on modify and stroke risk factors. As you probably know, hypertension is the #1 risk factor for stroke, and both the first stroke and recurrent stroke. And 20% of the resistant hypertension means blood pressure is not well controlled, and even patient take and 3 or more drugs. The device-based modulation really focuses on autonomic system, particularly reduces sympathetic tone, is really a great approach. Here, I just want to kind of show you the eye approach. You just insert the electrodes to your left ventricles, and there will be and change the contraction and upward actually can influence the blood pressure. And major really focus really work on is the carotid bulbar area, which has pressure sensors, and through the pressure sensors can actually influence the autonomic systems, influence the sympathetic pathways. Um, and there are several ways you actually can do it. Either you can put it innovative approach and put a stent over there and then stimulate the and barrier receptor, or you can just simply do electro stimulation through the electrodes, and or you can just do a carotid body and abrasions using ultrasound device, but and that cell phone has some safety concerns, or you really target on the renal nerve, also can tremendously change the blood flow, and the blood flow, and also change the and blood pressure as well. Here, really kind of show you there's quite a bit of studies has been done in the last 10 years. Maybe as a neurology, we just not quite familiar with those studies, but there's a very busy slides, but the take-home message is really um, and with those neuromodulations, those equivalent to take at least one medication, and change the and the systolic at the office setting, and you can look at it, sometime range between the and 10 millimeter mercury to almost a 20 millimeter mercury. So it's pretty powerful, and the tools to reduce blood pressures. Due to time, I cannot talk more, but there are ways in your modulation that you can help you to quit a smoking and moderate your glucose control. There's just a lot of tools those days. Yeah. Let's spend a lot of time on stroke recovery. As you probably know, and stroke now is a leading cause of disability. A lot of patients survive from a stroke, and motor impairment is the most common complications. Of course, there are other complications such as spasticity, pain, sexual dysfunctions, insomnia, seizures, language issue, cognitive decline, mood, and it's very suffering for patient and with a stroke, um, and uh, um, and we really need effective ways to mitigate those various impairment. Um, the tool, there are quite a few tools, as I mentioned early, but a common tool you probably heard about those non-invasive tools called the transcranial magnet stimulation. Again, use magnet field to generate electrical pulse. If you do high frequency, it actually can excite the brain inhibitory. At low frequency, can inhibit the brain. The setup is a little bit more expensive, but in general, it's pretty safe. And on the right side is transcranial direct current stimulation. Use very weak current, and it's very simple, and a setup and cost is pretty low, and depends on the electrode placement, and it can be excitation or inhibition, but it doesn't generate action potential like a TMS. Want to talk about, and when TMS was first invented, really meant to invent for stroke recovery. There's a lot of enthusiasm back in the 1980s, but then realized and improve stroke and recovery is not easy. And part of our understanding about the stroke recovery process is also not yet completed. So so far we still don't have a good evidence to show RTMS is effective and improve motor recovery in stroke. So as an initial study, one of the largest study was done several years ago, and really targeting patient between 3 to 12 months. Use low frequency, actually targeting healthy contralateral part of the contralesion part of the brain, and they do in 30 minutes, a 1 hour stimulation for 3 sessions, and followed by an hour and a half of therapy for 18 sessions. But the unfortunate study didn't really show any separation between the group. And the bottom shows really at that time they believe the sham coil is not really sham coil, still provide adequate stimulation to the brain. They redesigned the coil, did another in a single arm study, and just put a placebo group, but they still couldn't really demonstrate the efficacy of RTMS. With this, we lose a lot of enthusiasm RTMS for stroke recovery, but the study in South Korea also negative, but it shows patient in the subacute phase or patient with a subcortical stroke maybe have a better response to the RTMS. So hopefully, that the study is ongoing. Hopefully that will give us some positive news in the near future. Other developing in the RTMS in the world is really developed called a new paradigm of stimulation called theta burst stimulation. It's a little bit different and basically provide a train burst of low intensity RTMS rather than do the regular just regular stimulations. It turned out and it can generate a much prolonged excitation or inhibition to the cortex. And recently there's a paper published on the stroke from in Netherlands, really shows they are very promising data. Most important is that they only need to stimulate the brain for 40 seconds, really have a very prolonged inhibition excitation to cortex, so becomes very efficient and cost effectiveness compared the traditional stimulation. You have to stimulate the brain at least for 30 minutes or 1 hour. Sometimes can bring some discomfort to those patients. Again, tDCS I just talked about, it's much easy and to administrate and also can do concurrent stimulation and rehab at the same time. And our lab has been spent the last, in 12 years really study this device, how they can influence the cortical excitability. And then we really come up a high dose approach and really escalate dose to the 4 milliamp. And same time, we also develop an imaging biomarker who we believe is select the patient a little bit better. And with this, we actually able to get funding from NIH, $9 million to do a Transport 2 study. The study really just tests the idea is whether the high dose group with 4 milliamp and the low dose group with 2 milliamp was a sham, which group shows, and a better efficacy. All those patients receive high intensity therapy called constraint induced movement therapy, and we are targeting between 1 to 6 months. And as you probably know, there are some patients with very robust spontaneous recovery. We use 2 baseline to exclude those patients. And because regardless which group they assign, they're going to do better. And we both assess an immediate effect after 10 sessions, also sustained benefit, basically benefit at 3 months. At the same time, we test the idea, we believe that assessing the cortical spinal tract status after stroke is very critical and for patient selection. So either use imaging to look at the structural assessment and integrity of the descending motor tract, or use a TMS, use a single pulse TMS to see if we can induce the motor evoke potential as a way to assess integrity of the cortical spinal tract. So the study was done in its 5th year. we just need 4 more patients. Hopefully, if we can finish the study and then present in an international conference next year, if it turn out to be positive, I think that would be good for the patient because tDCS is a very simple, low-cost tool to implement in the clinical settings. Are there any invasive device has already received FDA approval? Yes, the vagus nerve stimulation has just gained FDA approval in 2021. It's a minimal invasive procedure, as you can tell. Make a very small incision on the neck, expose the vagus nerve, put the electrodes, put the Teflon, protect the electrodes and the nerve, and then you close an incision, open another incision, put the batteries on and connect them together. And the bottom you can see there's a physical therapist have to make a 300 to 400 click when patient initiates some of the movement. What they find is pairing with stimulation with therapy, and it can elicit more neurotransmitter in the brain and make the brains more processable and at a better position to have a good outcomes. The study really was done is basically 90 minutes for 3 sessions, 6 weeks, and then you can look at it. It shows over here is 3 months after the 6 weeks intervention, 47% of patients actually are classified as responder, means they gain 6 points on the Fugal mile, means their motor impairment really significant reduced. Was the sham group is only 24%, and absolute risk benefit, the benefit is 23%. Number needed to treat is 4, means for every 4 patients they implant with a vagus nerve stimulation, 1 patient will benefit from the procedures and stimulation. Similarly, if you use a Wolf motor function test, is measure the motor function, right? And every 3 patients, and their motor function will be actually and be improved and had to classify as a responder. So device was again approved in 2021, and several academic centers started offer to the patient, but it is not at low cost and device. Hospital bill is over 30,000, and plus a surgical procedure provided and billings to the providers. It adds up a lot of costs, and there's only 30 plus cases now implanted in the U.S. just due to high costs, and a lot of insurance companies doesn't want to cover. But I think things started changing a little bit. But really, this highlights, we need to think about it. Is implementation science even before you plan clinical trial. Is your device affordable? Can be adopted by stroke populations, right? If not, you simply invent an effective device, but will never actually gonna be used by the patient. And it takes time. There's an article saying it takes 17 years to change your practice. So it really takes your whole life actually to come up with one treatment. Anyway, other exciting things really use epidural stimulation along the corticospinal tract. This is a stimulation implanted on the cervical spinal cord when the corticospinal tract descending through the spinal levels, cervical spinal levels. Only 2 cases been done by the UPMC group. One had a very small stroke, the other one seemed to have a larger stroke. One and a Fugal mile 35, moderate impaired, gained 12 points. And a simple you turn on the device, patient even didn't receive any rehab. So the patient actually already do things much better. Second case, Fugal miles of 15 points out of 66, pretty low functioning patient. Only gained 3 points and after implanting the device. We think the corticospinal status probably gonna decide their response to this epidural stimulation. Other way you put epidural stimulation is put on the motor cortex, put an electrodes array. Now there's a lot of brain-computer interface technology, closed loop now has a very similar approach. This episode trial was done several years ago, and it turned out to be negative, but they found the patient, if they have positive motor evoker potential, those one are more likely to respond to the electrostimulations. So patient selection is very important. Deeper brain stimulation in the cerebellum really target the downstream of the corticospinal tract. Also, and again, quite attention and in the last few years. This study was just phase 1 safety studies. Everybody receives a DBS implant on the dentate nucleus. Through the stimulation, provide feedback to thalamus. Through thalamic cortical projection, further provide feedback into the motor cortex, and then, and then through the descending corticospinal tract, influence the motor function. Interesting, similar things. There are a small group of patients had a significant gain, but they are not sure. But not everybody gain. But it turned out to be very safe studies, and so they are doing the phase 2 studies at this moment. And you probably also know this is called BrainQ studies, and Joe Stan at Columbia is actually the PI for the studies. It uses a very low frequency, low intensity electromagnetic field stimulation. Really use the magnetic field to and engage in the neuronal firing to come up a pretty nice and a device like a wheelchair. Patient sit over there and for 30 minutes and then followed by rehabilitation. This study was had a very exciting study, was a single center study in India during the COVID, and then they move on very big pivotal study. Unfortunately, I think is being shut down due to lack of efficacies. You probably heard of ultrasound stimulation. This is new paradigms. Ultrasound can be used diagnostic tool, also can be the high intensity focused ultrasound already being used at clinic, to provide a relief for patient who cannot, and have a DBS surgery. But this is a low intensity, doesn't have a, the thermal effect. There are several proof of concept study. Our labs work on stroke patient, and we hope to publish pretty soon. It's actually had a very good data. Unfortunately, I cannot share with you this moment. Also, I would think we need to think out of the box when the interventionist doing endovascular stimulations. They put electrodes and stent over there, and then they maybe our tools can collect high quality EEG or service a tool to stimulate the brain. The picture shows above really kind of show you in the suprasagittal vein, which is right above the motor cortex. If they have it, in a deep venous thrombosis, you take off all the clot. If you leave the just called the central over there, you actually can collect a very high quality and EEG, and you can use a brain computer interface approach. Or soteric device stents, maybe they can also for recording as well, right? And the web device use occlude the large aneurysm. Well, you leave there, maybe you can just use those way to stimulate the brain, so those patients actually can getting better. So it's just proof of concept. Probably need much work we needed to do, and before we really can test the safety and efficacies. Anyway, stroke recovery, we need to use brain plasticity to recover the brain. If patient have a mild stroke, we already have a good evidence. All we need is to give more therapy. So please write a more prescription to the patient. Majority of those patients will live normal, okay, with adequate therapy. If patient had a moderate stroke, still have a neural substrate, we need to define the threshold a little bit better due to time. We actually did some of the work. If the cortical spinal tract lesion load accumulate to 7 cc, patient probably not going to be able to recover it. But less than 7 cc, if you do brain stimulation intensive therapy, we might be able to help patient live near normal. They may not be normal, but you can boost the one level function. We all have to acknowledge there are bad stroke. There are minimum or no neural substrate left after stroke. Maybe we need a cell-based therapy to induce stem cell, use exoskeleton, maybe bring computer interface, use, interface, use a healthy side of hemisphere to control both in, arm and legs. With this, we maybe help patients to find a different way to live. Maybe their impairment level is the same, but their function level is way different. Maybe that's the future. And with this, I'll just pause over here. Welcome any questions. Thanks for your attention.
Thank you, Dr. Feng. That's a great talk. That concludes our symposium for the day. I wanted to thank again all the speakers, especially Dr. Guzman traveling from overseas to come to visit us and enlighten us on very, very promising and also exciting work that you have conducted over the last 20 years or so. It's really enlightening. And also Dr. Feng offered our new hope in the future with the rehab recovery after stroke, and also all the speakers who really provided a great forum for discussion. We'll continue our work. We'll see you next year. Have a great evening and long weekend. Thank you.